David, great to see you at the first annual HemOnc Pulse meeting here in Chicago. So we just finished the session on unanswered questions on AML. Maybe summarize these unanswered questions and your reactions to if we missed anything that should have been addressed.
Yeah, thank you so much for having me, Chadi. Yeah, no, I think it was a great panel discussion. Touched on a lot of really interesting things that are going on in AML. I think some of the big unanswered questions that they addressed were intensive chemo versus vidaza-ven. You know, we talked a lot about, this sort of patient 65 to 75 might not fit the classic criteria that was used in the VIALE-A, but a lot of these patients could potentially benefit from vidaza-ven, and we need a randomized study comparing these to better understand what patients would be best for vidaza-ven therapy, what patients would be best for more induction-type chemotherapy, and that should be coming out in the next year or so and would be able to clarify. The other thing that we focused on a lot was the duration of venetoclax. And so in the VIALE-A trial, it was 28 days of venetoclax. And so really what we've started to see is that regimen can be very toxic and most people don't tolerate it. And so what we've now done is shorten that duration. So, 21 days, 14 days, and some, places even do 7 days of venetoclax in combination with vidaza. And that really lowers the toxicity and a lot of times does not affect the response rate. And so when we think about our very elderly patients, we are starting to use these true lower intensity options and really getting great effect. The other thing the panel focused on a lot and had a long discussion on was AML MRD.
And you know that topic is very dear to our hearts.
Yeah, exactly. It is. And because we're learning a lot about AML MRD, but we're still kind of at the very tip of the iceberg. I think we know a fair bit about NPM1, core binding factor, FLT3, but there's a lot of unanswered questions when we talk about MRD. We know transplant, decisions can be based on MRD, but what about therapy decisions? And so can we stop, vidaza-ven-based therapy in an MRD negative patient for NPM1 mutant disease? If a patient has MRD, that is trending up over time, does that patient benefit from adding on therapy before they have a morphologic relapse? Because the reality is when they do relapse, they tend to do poorly. They get sick quickly, and so if we can intervene early and show that that has a survival benefit, it's probably worth doing. But we need to look at that in studies. I think the final thing was, therapy-related disease. Again, the panel talked about it. I think we're sort of moving away from treatment-related AML or therapy-related AML and really focusing on molecular subsets. So, a lot of them...
It doesn't matter, treatment or not, it's the molecular piece.
Yeah, so a lot of them are TP53 mutant disease, which is, an unanswered question in itself. But when it's not TP53 mutant disease, most of the time investigators are treating them as you would otherwise treat someone that has that molecular mutation regardless of, whether they got therapy or not. For example, I have a core binding factor patient that had, treatment chemo prior, but cleared their MRD. We didn't take that patient to transplant, even though they were considered therapy-related AML. So.
Well, I'm really happy to have you here, and we're going to keep doing these meetings, try to hopefully next year some of these unanswered questions will have a little bit more answers to, and looking forward to having you on board all the time.
Yeah, thank you so much, Chadi. See you.